What are some of the principles that you help guide clinicians to making adjustments more effective rather than just being forceful?
Yeah, that's the huge one, especially because when people look at my videos and how I adjust, they go, God, you look like you are fucking people up. Like I am a forceful adjuster, okay? But it doesn't mean that the adjustment feels brutal.
Sure.
And so what you want is an adjustment that feels powerful, as in it's experientially powerful to the patient, but is smooth.
Yep.
And that is the sweet spot there. My analogy that I like to use for this is like hitting the sweet spot on a baseball, right?
Yeah.
Now, if you've ever hit a baseball exactly right, boom, it's like the bat just glides through, the ball's not even there. You don't feel any reverberation through the bat into your hands. When you hit the ball wrong, there's this concussion, this reverberation that comes up the bat into your hands. You go, oh God, that felt awful. Like that hurt.
Yes.
And that is the difference between a smooth adjustment and one that is not smooth. To me, that has everything to do with lining the joint up properly. And that doesn't mean to a perfect anatomical model that we learned in school. That's what I was talking about earlier, the line of drive, tweaking it for each individual patient. Making sure that the patient is truly relaxed before you thrust so that you're not thrusting into tight musculature as well. When the joint's not lined up really properly, that's where you get that adjustment that feels, really forceful and rough. Like we've all probably had an adjustment where you get up, you're rubbing your neck, you're like, oh, Jesus fucking Christ, doc, right?
Yeah.
That was a less precise adjustment. And I'm not going to say I've never done that. I do that. Sometimes I have patients, they text me the next day, hey, I'm really sore. I was like, yeah, sorry. But I'm doing my best to have that not be the case. When you get the joint lined up just right for that patient, the force goes in one side of the joint, sails through, out the other side of the joint effortlessly.
Yep.
Like the sweet spot on a baseball. It's like there's no reverberation or concussion of forces inside the patient's body, and you get this super smooth feeling adjustment. And if you've never had an adjustment like that, it's hard for me to explain to you. Like I've had docs come to me and they've said, I've never had an adjustment of my neck that didn't hurt. And then I adjust them, they go, I've never felt anything like that.
Wow,
that was
I had that last
so
week, actually.
Wow.
With the jaw too, yeah.
Man.
They go, I've never had anything like that. It was such a powerful experience for me, but it was so smooth. I almost didn't even know how to react. Like it almost seemed like you didn't adjust me, but you obviously did. There was this huge loud cracking sound. Like you can see that in their face, they're just shook.
Yes.
They've never seen anything like that. And I'm like, that's what I mean. That's what I mean by smoothness, being lined up exactly right. Right. You shouldn't get up off the table going, oh, fuck. Like, yeah, you really got it. It should be a smooth experience. And so that's the big thing that I'm trying to teach in my courses. And it's hard because it's a soft skill, right?
Mm-hmm.
I'm trying to teach people to take a basic framework because I have to teach the framework. Here's generally how we adjust someone. But I'll typically pull up a couple different bodies. I'll try and pull up a big burly guy. I'll try and pull up a very petite woman. I'll try and pull up a really bendy person. I'll try to talk through the differences in adjusting these body types and what changes in my line of drive, what changes in my setup I'm going to use to accommodate these different people in their varying anatomy. Longer necks, shorter necks, thicker necks, thinner necks, hyperlordotic curvature, so excessive curvature in the neck versus straightening and like more military neck. They all require different vectors and different approaches. And so you explain at a basic level what we're trying to do. And then as everyone breaks out, I'm going around and helping people. And one of the big things is when I can see their line is maybe not right or their pretension is not right, either too much or too little, I'll go up and put my hands on their hands. And I'll feel into the joint using their hands to palpate. I feel through them and guide them. Okay, do you feel this? And they go, yes, I feel that. Okay, now watch when I tilt him back, do you feel that close down and become less receptive? Yes. When we tilt forward, do you feel that open up and become more receptive? Yes. Okay, we want to go for this more receptive area. This is a key concept that I teach in my seminars. When you find the most restricted segment, you've won. You've already found the most restricted segment.
Yep.
There's no need to find the most restricted vector at the most restricted segment. And this is what they teach us in school. You find the segment that's not moving properly. you bring it to maximal end range, maximal lockup. So the shittiest feeling part, right? And you thrust through that. Why? I already found the most restricted segment. I can position that as open as I possibly can in a way that is the most receptive to force. And when I adjust it, I will clear that joint. Why? Because I'm already on the correct segment. There's only one joint, obviously there's a bunch of joints, right? And the facet joints and whatever, but you're only targeting one level realistically, like you're trying to. And so I don't need to take the most restricted, hard brick wall path through that segment. I always want you, my students, and anyone who's trying to adjust, I encourage you, try to find at the most restricted segment, the most open feeling vector that is likely to be the correct vector for a smooth adjustment.
Okay, so on that regard then, and we can take an example because I think this would help a lot clinicians and maybe more cementing my understanding on maybe X patient. So like, for example, like if a person opens their mouth, it deviates off to the side, comes back to center. You may feel like the condyles are either restricted or not enough space on the one side that I think it deviates opposite to. You want to adjust both sides of the condyle, like the side that is opposite from where it deviates, and then the other side to re-stabilize the condyle joints, or where's your thought process on one side adjustment of the jaw versus both, versus neck maybe?
So there's a really technical answer to this, and then there's like the caveman answer to this. And what's funny is that they're both true. Okay. So now I tend to joke, like I like to keep chiropractic really simple. I call it caveman chiropractic. All right.
Love that.
Joint doesn't move good. I smash the joint. Joint moves better now. Caveman chiropractic.
Perfect.
Now, you have to have a lot of technical knowledge to be able to take a stupid, simple approach like that, right? I have to know it's safe to adjust. I have to know all the contraindications, indications. But once you've realized that it's safe to adjust, you can take a stupid, simple approach of let's just adjust it and see if it's better. So, if I think the left side is the most dysfunctional, I'll adjust the left side. Then I'll see, has what I wanted to change occurred?
And is that
If
where
it
your
hasn't,
fingers are, opening and closing?
yeah. So for your indicators, you can look at the condylar motion. That's an indicator usually of disc dysfunction, and especially in unilateral cases. So when we see this deviation of the jaw off to one side that corrects back to midline, it's usually a sign of anterior disc displacement with reduction unilaterally, so on one side. So one side disc is normal or potentially anteriorly displaced without reduction, so it doesn't reduce. But the shift and then correction is caused by the reduction event. So as the condyle is trying to get over the disc, we start shifting towards the restricted side. So your jaw will path initially towards the side that does not yield its range. Right? So imagine that we have a rope here, two people have the rope. If I give you slack, the whole rope moves towards you. Now, if I'm giving you slack, am I restricted? No. Now, if I'm not giving slack, the rope will move towards me. If I'm not giving slack, am I restricted? Yes. So the restricted joint will not give range of motion. So the whole jaw shifts that way as the other side gives, and this side, the restricted side, takes, right? Now, if the restricted side does eventually manage to get onto the disc, we're going to snap back to midline. We're going to have this correction, right? As we get onto the disc and we have proper pathing and range on both sides evenly again. Then what you tend to see is as they close, they deviate back off to the side because they snap off the disc again and then close. So we tend to get this pattern of deviation, correction to midline, deviation, correction to midline. Now that would be called a deviation, which is where it corrects to midline. Now, if you never reduce, so you never get back onto the disc, you'll deflect, which is a permanent. So we start moving to the right, and all the way at maximal opening, we stay stuck to the right. It means that we're still, even at terminal opening, not getting back onto the disc, whereas on the other side we are. Now, then people are like, okay, well, what if it does this? It's like, yeah. So then we have disc dysfunction usually on both sides with reduction events occurring at different times during opening. So we start to open, we get an initial, pathing, maybe straight, maybe off to one side. we get a reduction event in one disc, right? And then we path another way. And then the other side, we have a reduction event and we path a different way. We get this really crazy presentation.
You
Right?
call that more like an S-like pattern in a way?
It can really be all over the place. It could be midline, right, left. It could
Yeah.
be anytime they deviate from midline, return to midline, and they're not fully open. That's when you're going to have something like this. So usually if they deviate and then return to midline at maximal opening, it's a one-sided dysfunction. If they deviate, return to midline halfway through, deviate again, whether it's the same side or the opposite side, they deviate again before hitting full opening. That's now usually both sides
Got
that
it.
are involved.
Thank
Got
you
it.
for that. Interesting. Okay.
So, all of this really does for us is it gives us a better understanding of what's happening at the joint. In terms of the practicality of it, you're going to adjust a joint that is restricted. So, does the right side feel restricted? Yes, adjust it. When you're done with that and you check the left side, does it also still feel restricted? Yes, adjust it. Now you've done a bilateral adjustment, right? If the right side felt restricted, the left side didn't really before we started. I adjust the right side, and now the left side feels good. The right side feels good. They feel evenly moving. Now I'm doing a unilateral adjustment. So I do that fairly often. I'd say 70% of cases are going to get bilateral treatment because they have bilateral dysfunction. But yesterday I did 2 or 3 jaw adjustments, one side only, because after I treated the dysfunctional side, the other side felt the same to it. So it felt normal on both sides. Okay, we're done, right? Oftentimes, what is the case though is I'll treat what I would consider the most dysfunctional side. I check the other side, and now comparatively, so that's the side that used to be worse now feels like their better side. Right? So the other side is still all fucked up, and I'll go adjust the other side.
Okay.
So, and my thought process there is, I don't think joints are like binary, like yes, no, restricted, restricted, yes, not restricted. Like that doesn't make sense, right? It's either completely 100% restricted or not restricted at all. In what world, right? So you can have a joint that's 80% restricted and then the other side is 50% restricted.
Sure.
Now, do I want to clear the 80%, say, wow, I was super specific, and then leave the patient, right? Or do I want them to walk out of my office with the least amount of restriction possible? That's what I want. So people ask me, why do you adjust bilaterally so often? I was like, because patients come in bilaterally restricted so often. If the patients didn't come in that way, I wouldn't adjust that way. Sure. It suits me just fine to do 2 adjustments instead of 13. Well, why do you do 13 adjustments? Because they've got 13 areas that need to be adjusted, right? Yep. I'm not in charge of it. It's not my opinion, right? It's how they're presenting.
Yes.
Mm-hmm. With that, and I thought about this, like the order of the adjustments, the most restriction, less restriction. I know for chiros, it's hard to adjust the same side twice. You almost have to go right, left, and if you want to go back to the right side. The dysfunction of some of the joints or bones in the neck essentially affect the order or your thought process when adjusting the jaw, or do you go at the jaw first, then lower?
So in terms of practicality, I just want to make everything as comfortable as possible. What I've seen is that adjusting the neck first makes the positions we have to put the patient in to adjust the jaw more comfortable.
Got it.
So even if I maybe wasn't clinically absolutely needing to adjust the neck and the upper back, I oftentimes will, because it's going to make positioning and the manipulation or adjustment much more comfortable when we get to the jaw. Now, if the patient doesn't want their neck adjusted, we don't have to, right? But there's also a lot of interplay between the upper back, the cervical spine, the headaches, and the jaw. We can get into that in a bit if you want. So oftentimes patients get better when we're treating them as a whole. I personally think it's foolish to treat headaches, TMJ, D, and neck conditions as completely separate. I think we should be treating them as a whole.
Yes.
And we can get into why. But in general, I'm going to do cervical spine first, upper thoracic spine second, because those regions are mechanically interdependent, and then go up and do the jaw last. We tend to get better releases that way, better relaxation that way. You will find, like, for example, if you try the left side cervical spine, it doesn't go. You try and go back to the left side before going to the right side. You have a very hard time making that work. And I think it's kind of like motor learning. So the patient has the experience of the impulse and the thrust. The brain learns, okay, now I know how to resist that, right? You go back a second time, they feel tighter, stiffer. It's harder to do. If you go over to the other side, adjust that, you succeed, you come back to the other side again. Oftentimes you'll succeed when you come back to it. And I think it just has to do with the way that the nervous system is processing that input. And then to your point of, should I adjust the most restricted or the less restricted areas first? That is, on a practical standpoint, I think more about patient symptom response. So I have a patient who has tremendous amount of pain. The right side is definitely the most restricted, but it's incredibly painful. I don't want to hit the right side, have it be so uncomfortable that they're like not going to give me permission to do the left side. So for certain patients that are very sensitive, I will ease my way in. Like I've even had patients who are so hesitant about getting adjusted. I adjusted their fingers and like their wrist first.
Well, I
I was
like
like, hey,
that.
would you be okay with me now adjusting your shoulder? I adjust their shoulder. Would you be okay with me now adjusting your thoracic spine? I adjust the thoracic. We start working our way up in intensity to the thing that most people are most anxious about, which is the neck or the jaw. So we might completely end with the jaw after doing everything, especially if they're very anxious or very sensitive. But if the right side is so sensitive, I might start by adjusting the left side, which is going to be a more pleasant experience for them because it's not as sensitive. And then they're going to give me permission to work on the right side, even though it's so painful, most likely. Now, sometimes that backfires because I have had people where I adjusted the less restricted side and they're like, I don't want to do that again. You're like, oh, well, that's unfortunate because I really should have started with the side you needed more.
But some
But for
motion
people,
is better than none, so maybe that did help anyway.
correct. And then, as long as you haven't completely scared them out of town or out of your office, you're likely going to get a second at bat when they come back for their follow up visit. And then maybe we start with the most restricted side next time.
Sure.
But for most patients, I'm going to start with the most restricted side and just knock it out because what I'm always wanting to know is the less restricted side truly restricted, or is its motion because of this major restriction? Is that just going to resolve after I do the adjustment? So if it resolves after the most restricted side, I'm going to stop and call it a unilateral adjustment. If it's still dysfunctional, even after I've done the most restricted side, then I'm going to drop bilateral adjustments and we'll see how they come back next visit.
Sure. That's awesome. I got a question. So I'm assuming people, if they're watching some of this content, they've seen you adjust the jaw where part of the hand is on the jaw and then other adjustments, they're having their head rest on a pillow. Do you have a preference? I'm assuming it depends on the patient and the restriction of the necks and a bunch of other things, but what way works best for most chiropractors maybe starting to adjust the jaw? What's your thought process between the actual manual of the different contact points?
So they both have individual use cases and individual vectors, right? So the one where the head is turned to the side, they're laying on the pillow, that is what I call the TMJ toggle. That is a long axis distraction vector. So I'm not trying to take the jaw and pivot it and then glide it forward in its normal physiologic range. I'm actually trying to gap the condyle inferiorly away from its home on the temporal bone in the hopes that if there is a disc displacement, the ligament will be elastic enough that when I gap it, the ligament pulls the disc back. Or if there's not a disc displacement, this is essentially a decompressive adjustment for the jaw. So when the jaw muscles contract, it shoves the condyle up into the temporal bone. This is an adjustment that counteracts that direction of pressure and then can be alleviating. It's also the simplest vector and simplest line of drive, the simplest setup, because I'm not having to use a stabilization hand to control the patient's head position. So for clinicians or students, when they're first learning to adjust the jaw, the TMJ toggle is the most controllable. I have access to both my hands to apply force, so I have access to more power, more speed. The line of drive is very straight and straightforward down towards the patient's sternum. And there's a lot of control of external variables. Most people struggle with what I call the face punch, which is where I'm holding their head and doing it, because now we have lateral flexion and rotation involved. You have to control with your stabilization hand the same way you would for a supine cervical. You have to significantly limit the range of motion that occurs so that we get motion at the jaw and not in the neck. We accidentally strain the neck. But now you only have access to the speed and power of one hand. The trade-off is the face punch can do both. The face punch can do a long axis distraction vector of thrust to gap, but it can also do a P to A vector where we're getting more of that actual anterior translation out of the condyle. Important distinction, if you have an anterior disc displacement, the disc is in front of the condyle. If I now use a P to A vector on the face punch technique, I'm going to shove the condyle into the disc and create acute sprain. Now, it doesn't mean you're going to literally sprain the ligament, but in an anterior disc displacement, the P to A vector face punch technique is much less appropriate because the disc is going to be impacted by the condyle and you are at risk of putting excessive strain on the retrodiscal tissue.
That's cool.
So for that type of patient, the toggle or the face punch with a long axis distraction vector is more appropriate. But in the case of a patient who has joint restriction can be in any vector. So it could be in long axis, but it could be in that P to A vector. So sometimes when I'm feeling on that face punch palpation, I feel there is a P to A restriction, and I've identified that there is not anterior disc displacement. Now this patient is a great candidate for that P to A vector on the face punch technique because we're going to more appropriately address their restriction while still trying to find an open way to access it. So I'm still not going into the most restricted vector, but I'm going in a more appropriate vector. Now, even if that is the case, the restricted P to A, you can still have very good results adjusting long axis. Anytime you gap the joint, you can still get great results. But there are situations where that P to A vectoring on the jaw is more appropriate, and there are situations where I believe it is quite inappropriate. And usually clicking and popping of any variety is going to rule out the P to A vector on that technique for me because I'm not exactly sure where the disc is at any given point, and likely in the closed position, the disc is anterior. And so I don't want to shove the condyle forward into that disc.
That makes a lot of sense. Does opposite side tissue slack of the jaw when you're holding the jaw condyles, like on the punch adjustment, matter that you've noticed?
So for that technique, like the face punch, I'm actually not contacting the jaw on the stabilization hand much at all.
Okay.
My fingers are going to go underneath the skull and the cervical spine. The goal there is to try and limit spillover force into the cervical spine. One of the key factors there is my thumb is going to be on the zygomatic arch of the patient. That's going to give me a lever to resist rotational force. So that when you don't have the thumb there and you just hold the head like a bowling ball, like a cupped hand, which I see many people try to do, when I put force into the jaw, there's an acute rotational and acute lateral flexion moment that you're putting in. And a lot of times that will go into the cervical spine. So when I see students do this a lot at my seminars, and the jaw makes a rather high-pitched cavitation sound. So I will watch and I hear a thunk, and I'm like, that was the occiput. So you can accidentally laterally flexion cavitate the occiput, or sometimes you hear, a variety of cracks, and then you've accidentally adjusted the cervical spine into rotation. Those are usually spillover force problems. And so the hand should be as wide as possible over the base of the skull, fingers going into the upper cervical spine, and the thumb reaches for the zygomatic arch to limit rotation and lateral flexion. And what I'm really trying to do is keep the skull as still as I possibly can, so that this hand snaps the force through the jaw, and this hand is trying not to move at all if possible.
Andrew, that is beautiful. Thank you so much for that. Oh, that's going to help so many people, man.
And then for the TMJ toggle, it's the pillow that controls the range of motion of the vectors. So they're stabilized on the pillow, and that allows me to then focus both hands on one side of the jaw while the stabilization is done by the table and the pillow.
That's beautiful.